Thank you very much, Mary and Kathy. It's nice to be here. It's a difficult time for everybody, and I think it's really important that we acknowledge the work and the support that is already going on in our disability services, and the creativity and the innovation and the practical approaches that are already happening. And in many ways, I think today might be about affirming and giving you permission to continue with many of these creative and practical approaches that you're already implementing. I think the other thing to talk about here is while we're thinking about isolation and we're thinking about an infectious disease, we're also thinking about self and safe relating. So how can we support people during this time to actually relate safely? So what we hope to cover, we're going to look at prevention, we're going to talk about well-being and reducing stress. What does quarantine and isolation look like, and how do we respond to distress when people are experiencing that in the context of all of the changes that are happening around them? There are many HSE guideline documents available on the HSE website. The link was there in the first slide. And I suppose just to all of our listeners from around the different countries, this is applicable to Ireland. Today, the 9th of April, we know that this is changing day by day, but these are some nice documents that do provide very important basic information. And even though I use the word basic, I should be using critical here. In particular, the third document there, Guidance for COVID-19 and Social Care Group Homes and Residential Services Disabilities. It's an excellent document and it's available on the HSE website. When we think about prevention, we're obviously thinking about stay at home, and we're thinking about the 6 steps, and we're thinking about the chain of infection. This is the critical thing in our toolkit. And I suppose everybody is living by this, and that includes the people that we're supporting, that they're actually participating in these routines and actually knowing about them and talking about them and being part of them and actually having a role in being preventative. So these posters would be available. We have many social stories that have made these posters a little bit more user-friendly. We also have accessible videos that have been made available to people. Many of our speech and language therapists have actually been developing videos with individuals as actors and hosts. And I suppose that's what we're talking about today, is how can we really be inclusive? Because this is one time when actually we are all doing this together. So I suppose just a tip of the cap to all of our colleagues who are doing already creative and innovative approaches in thinking about how do we make preventative care and the chain of infection available, accessible, and having everybody have a role in that. We've another kind of few weeks, if not months, ahead of us. They're going to be difficult for all of us, and in particular for individuals with intellectual disability, where there's difficulty with new routines and schedules. The change and the feelings of loss related to long established routines, especially the confusion around how long is this going to last? And for many of us, that's a question we don't have an answer to. So how do we punctuate this marathon? And how do we give key markers along the way? Because really what we're thinking about today is how do we instill hope? How do we actually balance those feelings of loss and these feelings of change with hope and in the context of well-being, without in any way reducing the significance and seriousness of the current situation? And then the support needed to understand what is happening with accessible formats available. So do we have all of these at our fingertips? And I suppose I hope today that we'll be able to share many links with you on all of the resources that I've already briefly mentioned. So what we're thinking about here is stress, and experienced by all of us, to be honest with you. And many of us have the responsibility to put in place our own well-being plan. And those hotspots, those indicators of stress, we possibly have already built in some preventative factors to kind of say to ourselves, it's okay, we can just do these 3 things at this time. When you do this, you have this to look forward to. So for many individuals that we're thinking about, they're going to need us to do that with them. So they're going to want us to be able to know that this is a worry, that this is a concern, that possibly WhatsApp or Skype aren't actually doing it for them with regards to contact with family. We know all of the factors that contribute to stress. Change in routine is one of the biggest ones that we all experience, missing family, friends and key staff, especially if staff have actually had to go on leave due to isolation and self-isolation. Fear of PPE is coming up quite a lot, and I suppose I'll talk to you a little bit about how we've developed different protocols and different desensitization and fun around PPE for the people that we're actually supporting. How we think about choice. So can we have Pancake Day on a Saturday now? And can it also happen on a Tuesday? Are we setting the table? Or are we bringing trays that have a daffodil in a vase? So when people are having their meals in their bedroom, how are we making this a very significant occasion for them? So this is what we're thinking about. So yes, choice is limited, but the choices that we do have, how are we celebrating them? The other thing I suppose that's really important is there are going to be beautiful moments, and there already are beautiful moments happening with individuals and the people who are caring with them and for them. So how do we capture those beautiful moments? So don't forget about putting in place some video diaries, some reflections of, wasn't this lovely today when we did that? So that people don't actually feel that this has been totally horrendous. But in actual fact, there were moments of celebration. So how do we capture those? Because remember, this will pass, and it will be nice to be able to reflect on, wow, we had pancakes 3 days a week. Do you remember that? Wasn't that the best time? And I think that's what we're trying to do here, is we're really trying to highlight well-being and stress in the context of resilience. Can we cope with this, and can we go the distance? One thing in particular that's coming up for us is the confusion around different shift patterns and different staff supporting them, and how important it is to have visual schedules, to have photographs of staff. We actually have staff interviewed. So we have iPads where staff are interviewed and they're actually saying with the calendar marking 2 sleeps and I'll see you again, because obviously we're very interested in maintaining the 48 hours of contact with regards to being in contact with somebody who has symptoms. So our shift patterns are being established based on infection control so that people know I'll be back in 2 sleeps. And if a staff person who's supporting a person is concerned, I wonder, are they worried about when John will be back? They can actually say, remember John said 2 sleeps and he will be back. So we're looking at ways to help people feel, okay, I can trust you. And in 2 sleeps, John does come back. And I suppose if that isn't possible, that John is able to video in and explain that he has a runny nose, that he's sick and the doctor has said he needs to be in bed. So that the information is accessible, it's available, and we're actually thinking about, would this be a worry worm for the person? So when would the person need to self-isolate? I suppose we all know this, but it's really important that we remind ourselves if they have symptoms of COVID-19, and obviously the GP is part of that decision-making framework, before they get tested for COVID-19. So if they're waiting, we are aware that there are kind of time delays with regards to testing. While they wait then for the test results, if they've had a positive test result for COVID-19, if they have any cold or flu-like symptoms, and again, under the GP or the medical consultant's advice, self-isolation is recommended, or if contact tracing has actually occurred and they have been indicated through contact tracing, which in Ireland at the moment is 48 hours, in the last 48 hours, contact with somebody who is either symptomatic and waiting for a test or has had a positive test result. Cocooning then is usually in Ireland for people who are over 70, but we obviously do look at comorbidity. So there are people maybe in their 60s and even younger who would be cocooning, who would be seen as medically vulnerable. And again, we would know these. Cocooning means the person stays at home at all times and avoids face-to-face contact. So that would be contact that is within a metre. So they're avoiding that. So at least a metre plus. And even within your home, the person should minimise all non-essential contact with other members of their household. So usually here, the person isn't showing symptoms. They're not ill, but they are medically vulnerable. So the first thing is really how is your service, and that can be your house, your group home, your area. How are you coordinating supports and how are you thinking about self-isolation? So with regards to contact tracing, testing, health screening, risk assessment, and a self-isolation plan. Now that sounds very posh, but it can be one page. It can be a half a page. But do you know what are your concerns around self-isolation? This is a really lovely document that the HSE developed for self-isolation facility, operational principles and guidance. And what they're asking is, do we actually know the numbers of people in each of these groups that we're actually trying to support? So the red group, this group are asymptomatic contacts, but are required to self-isolate through contact tracing, and the GP is actually authorising and approving, yes. They're asymptomatic, but we are going to be looking at a 14-day self-isolation period, and we need a plan then around that. So many of our services may have people in this red group. So they're asymptomatic, and we're looking at a 14-day window. So that's important to know. We then have a blue group. This group are symptomatic, but not necessarily and haven't tested COVID-19 positive, but they've met the criteria. Now in disability services, this is really important to think about because at the moment in Ireland, we have high temperature and cough. They're the two main indicators. Now, for many of us who are supporting people with complex needs, they may not actually cough. So they may not actually present with the cough. So it's really important where you have people who are presenting symptoms that the GP obviously is known to them, or that there is a nurse or medical staff available to actually think about the silence in the chest, because for some of our individuals with complex needs that can be a concern. So this group are symptomatic. So also know, so this group aren't well. So they've obviously got a runny nose, they've a temperature, maybe they've got muscle aches. So this group are presenting with sore throats, they could even have an ear infection. So the blue group are showing symptoms, but we are not, and it hasn't been confirmed COVID-19. The orange group then are the group are confirmed COVID-19 cases. So they have actually been tested and it's actually confirmed, and they can have with or without mild symptoms. And again, you have your GP, but you have a COVID-19 care plan, because this is a little bit different to self-isolation with symptomatic and blue group and red group. And we'll just talk about that a little bit. In the context of everything that we're doing, we're obviously always committed to a human rights-based approach, and all of our services work to a human rights model. Within that, we all know the articles, so I just thought I'd highlight just three. So equality and non-discrimination, because many of us are concerned maybe with deprivation of liberty at the moment. And I suppose the one thing I'd say to you is there's equality here, because none of us are being discriminated against with regards to deprivation of liberty. But I think the important point is that we still document it, that we still say that this was a difficult period, and we actually did deprive people of their liberty, and that was done at a governmental level, and it was actually equitable for everybody. And I'm going to look at the decision-making framework that our HSE and our government has actually set forward, because there's lovely principles and values in that to help us, I suppose, think about some of these very difficult decisions that we're having to make. Ensure the safety of persons with disability, Article 11, and Article 25, the right to highest attainable standards of health. Now, I didn't just gloss over Article 11 because that's really important. And ensure the safety of persons with disabilities. With that also comes obviously our own safety and everybody else's safety. So with a right comes a responsibility. And for many of the people we're supporting, those responsibilities need support, because sometimes people may not understand their responsibility to actually honour your Article 11 and your right to be safe and your right to actually work in an environment where you're not concerned about risk of infection. But we have a responsibility here to ensure that the people we're supporting have the maximum supports available to them so that they can actually honour their responsibility. This is the framework document I was referring to, and it came from the Department of Health. And it talks about legitimate restrictions on an individual's freedom can be justified in cases where exercising that freedom places other people at significant risk. In enacting any measure where personal freedom is limited, the least restrictive effective measure should be adopted. And remember, The reason we're actually doing this is to reduce the risk of imminent harm. So it's really important that we're able to talk quite freely about the imminent risk of harm and what are our supports and our control measures and what additional pieces of support can we put in place. So just very briefly, this is obviously a big document. I don't know, I think it's 20 odd pages, but I've summarized it into one slide. So thank you, Taoiseach. The ethical principles there are, and Dr. McQuillan would have referenced these in our last webinar, minimizing harm, proportionality, solidarity, fairness, duty to provide care, reciprocity and privacy. And the procedural values, reasonableness, openness and transparency, inclusiveness, responsiveness and accountability. Now these are lovely, lovely and critical values for us to guide and use in making decisions. So is this a reasonable intervention? Is this a reasonable practical approach? Have I documented it? Is there an openness and transparency around it? Have I thought about the person's voice in this and what the person is going to feel about and their values and preferences in helping them participate in this decision? Is it responsive? Is it actually going to meet the need at this time in this moment? And can I stand over it? Can I hold myself accountable to it? And should a slightly skeptical stranger approach me, can I say, this is what I did? So, and will there be evidence of that? So these are really important. So decisions that we make, what we're being asked to do is ensure that they're reasonable, open and transparent, inclusive, responsive and accountable, which does mean we are going to have to document our decisions. Now, when I think about well-being, and help me with time there, when I think about well-being, we have lots of different tools that we use for well-being. So well-being is as critical for people who are self-isolating as it is for people who are living a much more restricted and contracted life at the moment. So in St. John of God, for example, we use the Wheel of Optimal Living, but I'm also drawn to PERMA, which is Michael Seligman's work, where he talks about making sure you have positive emotions, making sure that you have a role in your day, that you're engaged, you're participating, that you have an opportunity for positive relationships, that you have some meaning, and that you actually feel at the end of the day, do you know what, today was an okay day, that you have some sense of accomplishment. The Wheel of Optimal Living goes into a little bit more detail, and these are kind of 5 key things that keep us all feeling well. So meaningful time and things to do. Boredom can be a devil. So how can I stay engaged? Is my environment, is my physical environment me friendly? So what is my bedroom like? What is my comfortable chair like in my bedroom? Can I open my window? What is my outside space like? Can I be outside safely and not have a cause of concern for imminent risk? What are my interpersonal connections and contacts like with my family, my friends? How can I bring the outside world in as well? So how can I actually still see the horse that I used to go horse riding on every Saturday? So we're not just thinking about loss in the context of we can't go horse riding, but this is your horse and they also have to stay in their field at the moment. Health, and I suppose I want to talk about health in the context of an awareness of diagnostic overshadowing. We have to be very careful that we don't allow COVID-19 to actually blinker us with a lot of the medical concerns that many of the people we support would usually present with. So I am thinking about constipation, I'm thinking about tummy aches, I'm thinking about earaches, I'm thinking about all of that, that we don't forget that many of the people we support would present with standard health concerns, and that we're not necessarily going down COVID-19 if this is an earache. Now, I'm not even suggesting that we would, but this is a time where diagnostic overshadowing could actually slip in. The other thing here is emotional health, and many of our psychologists and counsellors in Ireland are all providing telehealth. Some of them are doing it on video, some of them are doing it on phone, but telehealth is available and should be continuing for everybody as standard. The other aspect then obviously is your spiritual health. So I know in some group homes, Sunday Mass still happens at 11 o'clock and people will get up, they will get dressed, they will actually head off into whichever room the TV is on where social distancing can be maintained, and they will enjoy Mass together. So health is thinking about your physical, your emotional, your spiritual health. The other area then is skills. The communication passports are really important at this time. So pull out the communication passport, make sure that everybody knows the critical ways that somebody understands information and how somebody conveys information. You might say, geez, Caroline, is it a time to try new things? Yeah, do you know what? It could well be a time to try new things. So I do know people who have taken up chair yoga. I know people who are doing watercolor painting. They've never painted in their lives. There are now people potting tomato plants. So all of this can still happen in self-isolation, in particular for those in that red and blue group where they're asymptomatic or they're symptomatic waiting for a test. And then we've obviously got meaningful time. I've touched on PERMA. I'm going to keep going because obviously you'll be able to have a look at that. And I think also to acknowledge all of our services know and are thinking about well-being and reducing stress, and many have in the care plans detailed this already. So make this available in particular to new staff who are coming in, our staff who are returning from maybe self-isolation and are now coming back to work. So if an individual was to greet them at the door, what information would they love for them to have? And that's the information that should be shared. The other thing I suppose we would be saying is talk about coronavirus, talk about COVID-19 in a way that's factual. We don't obviously want to scaremonger, but we do want to say what it is, what's happening in Ireland, how we're keeping 2 meters apart. I've never seen so much duct tape and masking tape on floors, in kitchens, at doorways, so that people have indicators. This is where you stand when I'm talking to you. Because remember, we don't want to have a runny nose, we don't want to have a temperature, so we're doing all of that. We do a use of a calendar to pass time. Now we can't give the calendar with the end date in sight, but we can give a calendar to 3 more days to Pancake Saturday. 4 more days to, 2 more days to. So we can put in markers so that this marathon becomes measured. So people are thinking, I can't wait for. I just thought this is a lovely picture. It was in the paper there yesterday. It's Beaumont Hospital. So it's some of our medical team in Beaumont Hospital. And in the HSE, we obviously have an initiative of Hello, my name is. And this was there. I suppose it's just so beautiful, isn't it? And how creative everybody can be. This is me. So you can't see my face, you can't see anything about me, but this is actually what I look like. And the article just talked about the warmth and the smile that came through people's eyes through something as simple as this. And that can be really important for the people we're supporting, because they actually then say, okay, it is you, and I can see that. The other thing staff are doing is they're actually videoing themselves before they put on the PPE gear. So they're in their clothes, they put the PPE gear on over their clothes, and then they're standing there with themselves, and it's in the same video, and they're actually doing that so that the individuals they're supporting can see this is me, and they're also using the pictures. We're doing a lot of work around desensitization regarding PPE, testing, time in my room. We're using pictures, we're making role plays, we're doing movies, we're making videos together. We're obviously thinking about safe relating and how can we reduce fear and increase coping and tolerance for safe relating. Easy read videos, accessible and familiar environments with clear indicators and markers. So can the sitting room or the bedroom be arranged that we can have 2 chairs there? Do we know that when we go into a room that we open the window? We're thinking about things, routines, people, music associated with comfort. We're using candles, we're using battery operated candles, we're using lots of different things to create the atmosphere of this is a safe place and this is a comfortable place for you to be. The other thing we're doing is we're supporting people to actually spend time in their room even though they're not in the blue or the green, the orange or the red groups. So that people are getting used to actually spending time in the rooms before they're in any of those categories. So lots of things around desensitization. So I'll keep going here. So does your service have a plan? And the best plan will be based on strong foundations. So for many of our services, thankfully in St. John of God, we have very few people that are self-isolating. we have very few people who have tested COVID positive. So we still have time to put in place a lot of the things that we've talked about with regards to creating a foundation. Indirect and direct approach. So are you talking with the individual and their family about their well-being, about their worries and fears? Are you thinking already about routine visits, their role and meaningful time, space, new staff? When you're then coming down to the nitty-gritty of practical approaches, you have to have the biopsychosocial environmental approach, which is what we would use across all disability services. The tool we're picking up first is obviously the risk assessment, because it's very concrete, it's very measured, it's one page. And then we're using the AIIHPC, which is assessment plan, implementation and evaluation. So I just thought I'd give a couple of vignettes very quickly. So person A is living in a group home with 3 other adults, 2 staff available 24 hours a day. Isolation is required. They're asymptomatic, but due to contact tracing, they're in the red group. So we have a person-centered approach to stay in my own space. Now, I am using stay in my own space quite loosely, because it may not mean stay in my own room if the person can have a space that can actually be safe. And I'll talk a little bit about that. So on the left-hand side, you're going to see what the risk assessment highlighted. How are we going to do the health screening? Because remember, they're asymptomatic in the red group. How can I think about space inside my home? What routine can I have? How do we think about new staff? How can I think about outside space, which is very important for this individual? Contact with family and friends. This individual needs to know what's happening next. So we absolutely need to be thinking about that. And this person, when stressed, will cry and can absolutely refuse to eat due to anxiety and that feeling of butterflies and constant kind of, I don't know what's happening. So we obviously have a behaviour support plan in place, because this isn't just specific to this situation, and this is how the person often communicates. Who are you? What's happening next? So you can see on the other side, the self-isolation plan is very clearly now addressing the risks. And this is in the context of doing everything that the HSE has recommended in their guidance documents. So we're already thinking about being within 1 metre, we're already thinking about 2 metres, and we're also already thinking about safe relating when we have to have a reduced space, which is less than 1 metre. So you can see we have a social story, we have a calendar to mark days, we have my room with my chair and my TV, we have access to the garden at certain times, we have a WhatsApp group, we have a visual schedule with the preferred routine, we have pictures of all staff, the message is with crying is who are you? So how do we introduce new staff? And that always happens by familiar staff. Nice things we did today, so we have reflection at the end of the day, and we're constantly checking in with the family and checking in with staff. Because obviously they're our mediators, and if our family and staff are feeling well and confident, they're going to ooze wellness and confidence to the individual that they're supporting. Vignette B, so person B living in a residential setting, it's a campus with 7 other adults, 5 staff are available 12 hours a day, there's 2 staff at night time. So you can see this group probably has much more additional support needs. Isolation is required, this person is falling into the symptomatic blue group. Again, we're thinking about stay in my own space and a person-centered approach. We did exactly the same thing, risks to be supported. You can see some of them are quite similar. So our health screening with regards to test and care plan. So we now have to think about how might we help the person and prepare the person for the test. And in Ireland, we've very clear guidelines that a test is not obligatory, it's not mandatory, you can't force a person to have a test. But obviously want to maximise because the person has an equal right to a test. So we don't want to inadvertently discriminate because the person is saying no, so desensitisation and shaping is really important here. And we know that we could be waiting 5 or 8 days, so we have 5 or 8 days to think about this. We're looking at my room, we're thinking about hygiene, routine. This person actually can get quite concerned and engage in shouting. When we look over at the behaviour support plan and the message directly across there, we see it's come here please. So we really need to think about check-in times, and we need to give this person a good old-fashioned bell. And that's what actually happened, so that this person could call. Now, you may think we're going to have persistent bell ringing, but I think that might be a little bit more suitable than persistent shouting and distress. And obviously then maybe our check-in times aren't adequate. So I think you can hear that we're constantly reflecting, we're constantly moving with the person. We've now obviously got our health passport up and running because the person is symptomatic. So we've definitely had to update this. We've had to look at I'm sick social stories. So our social stories are very dynamic. I don't know, I think that we must have about 30 different social stories at this stage, and they're constantly being adapted, changed. We're looking at my room with music, TV, and this person loves to have fidgets. So they love to have different things available to hold, to move, and all of that. We have a very clear communication protocol for care tasks. So how we approach very specific care tasks. We have a choice box with activities and snacks. And that's just an example of a visual schedule, but some people actually need objects. So we obviously have Milton back in our lives where we're sanitizing and washing everything. We have nice scents. We also have wear a mask. So we're already introducing the person to a mask. So the person's been supported to put on a mask. In some of our services, now I don't know if this affects the integrity of the masks. Those of you who are more medical, you might let me know, but we might be drawing mustaches on some of our masks. Or we might be drawing maybe a dog and asking the person, you know, do they see anything funny about your face? So we're engaging with the individuals so that there's a warmth and a fun, because we don't need to frighten people. We have a visual schedule, and with this individual, the zoo, Dublin Zoo has a virtual zoo, and it's bringing you around to see different animals on different days. So the multimedia zoo is really important in this person's life. And obviously we check in with family and staff. Vignette C, person C is living in supported living with 2 others. They've drop-in staff once a day and they've no nighttime support. Isolation is required. This person has tested positive for COVID-19, and so they're confirmed in the orange group. So stay in my own space. I think the big concern here was with drop-in staff, we wouldn't be able to monitor their OBS and actually monitor their health sufficiently. So in this particular service, we have a self-isolation unit, and this person was transferred to the self-isolation unit where they could be monitored. So there are going to be times when maybe your self-isolation unit isn't available, but for this particular vignette, it was. We obviously were thinking about nutrition, hydration. We also had a how am I feeling scale. So we have supported people to indicate how they are feeling. Because remember, many of the people we support may not actually be able to tell you what's sore and where hurts and how they're actually feeling. So it's really important that you do think about pain scales or feeling scales. We got the social story, I'm sick. We've got the distress here with trying to get out of bed and I want to go back home, I'm fine. So the person is very much saying, no, I'm ready to go back home, and scratching hands and face. And this message, when we looked at the communicative message here, it was, I'm scared. I'm actually quite frightened to be here. So we did look at the accompaniment by a family and by a member of staff. So we have put that in place for this individual at this time. Obviously now we have to think about quarantine and self-isolation for the other 2 and for the drop-in staff that had had contact for 48 hours. So that sends us down another track. But now we know that these people are asymptomatic and they're actually in the red group. So we now can put self-isolation plans for people in that red group. So you're getting the idea that with isolation, distress is going to be natural. It's an absolute natural response, and it's actually a healthy response. It's what we do with it and how we begin to support it. So in our organization and in every approach, we're thinking about find the message. Can you understand why this person is shouting, crying, refusing to eat, scratching their hands? Behaviors communicate a message about the individual's current needs and situation. Distress, pain, confusion, coping challenges can all be communicated through verbal and nonverbal means. So what is the individual trying to tell you through their behavior? And based on the message, can you now problem solve? For example, can you adapt the environment, the routine, the people, the activities, the fun, the food, access to outside, the pain, hope, fear, love, your responses? Can MDT help you think about this? And this should be captured in the risk assessment. So for example, I want to go out for a walk, please. In one of our services, we have a gentleman who really needs to see the forest. And we have put in place he is in self-isolation, but we've put in place a procedure for the bus to be used so that he can visit the forest. Because in actual fact, it's going to be much less distressing for him if we can do this. And he is in the red, no, he's actually in the blue group. So he is in blue, symptomatic, hasn't tested positive for COVID-19. And using a risk assessment with measured controls, we've looked at self-relating in the context of this message. I want to sit on my couch in the sitting room. So we've actually looked at very creative ways to make the sitting room available to individuals. So if the other individuals are not self-isolating, can spaces be rotated safely so that people can still access preferred spaces in their home, and other people actually are out, or other people are in the garden, or other people are in their own bedrooms. I miss my day service. We have day service staff videoing themselves in the day service staff saying that there's nobody here, that the day service is closed. So you're getting the idea that how do we make these messages kind of accessible and held so that the person is actually feeling, okay, I hear you and thank you for telling me that. This might be a plan for the message of distress. These are all the areas that we'll actually think about. I won't go into this in much detail, but you can see that we're looking at the environment, we're thinking about skills, we're thinking about what are the stressors and how can we support those, and also when am I most calm, when am I most content, and how can we make these much more available. If the person is distressed, we're listening for the message, we're offering reassurance. We're obviously always thinking about the least restrictive approach to support safe relating as opposed to support self-isolation, because we, I suppose, are very reluctant to begin to think about having to physically move or touch an individual, whereas if we can use a least restrictive for self-relating, we have to obviously think about that. Are there going to be times where we may have to support a person to link us and walk with us, or support a person to come with us this way? Yes, there are, but I think we're doing that always in the context of, is this what's critically needed at this time? So we obviously are asked, what's best practice of supporting an individual who tests positive for COVID-19 who displays significant distress as communicated through behaviours of concern? Have you done a risk assessment, and do you know what this person is really being challenged by at the moment? What is their stressor? When is the imminent risk of infection to staff highest? And then think about your protocols for providing care. So when do you need to provide care and how do you do that? Think about the behaviour and what the individual is trying to tell you. I'm scared, I do not know you, I do not feel well, I want to walk around, I need to pace. When is the individual not distressed and calm, and can you increase these moments? What distresses the individual and why might this be? And how can you actually reduce that for them? Do you need two staff present, one to comfort and reassure and to eat a bag of crisps with the person, and maybe the other one to provide the care? What skills for relaxation does the individual have? Because they may already have skills for relaxation. So I'm thinking about one person and they love to smell lavender on a handkerchief. So we would be using essential oils so that the person has lavender and they can actually smell that on a handkerchief. How are you thinking about social stories and video information? And family support input and MDT input are obviously always available to you to think about it. I don't have the answer, but what we can do is problem solve together so that what we're doing is person-centered, human rights informed, and our commitment to avoid the need for restrictive practices. So I'm not saying don't, I'm saying avoid the need. Our aim is always to take a positive and proactive approach to reducing and eliminating the need to use restrictive practices in line with national legislation, organisational values and policies, our Convention of Rights for Persons with Disability, and evidence-based practice. If a restrictive practice is required, the ethical framework for decision-making in pandemic is adhered to and evidenced. So we have to be able to stand over our decisions, and I think the documents that the HSE are setting out for us are really, really valuable and critical. And I think if you're thinking about very complex situations, don't do that alone. Do it with your colleagues, do it with the individual's voice, and do document your supports and your decision-making framework. Thank you.